And our first speaker is Mr. John Spiegel. And Mr. Spiegel began his career in healthcare back in 1967 when everybody started PIM, the Program Integrity Manual, and this is the group that John represents. And so I'd like to welcome John to discuss Medicare enrollment as well as fraud and abuse.
I'll talk a little bit about what we're about. One of my favorite slides, I think that I have this hanging on the wall in my office. It centers me. It's why we all do the things that we do in the Center for Program Integrity. And if I'm ever lost, I can find the reason for why I'm doing whatever I'm doing at the moment in one of these points. Before I get into the specifics for each one of these, I'd say that since I'm up here and I can say whatever I want, program integrity work started a long time ago. But when Medicare first started, we didn't have the technology that we have today. We had, I'm old enough to remember paper claims and computers where it would fill a room like this with a whole bunch of them with spinning reels. And now, laptops and desktops can do things that whole rooms of computers used to be able to do. We were lucky if we could count how much money we paid in an era when we were about prompt payment. Prompt payment was a real problem in the beginning, as some of you will no doubt remember. We couldn't get it done on time. Now we get it done too fast. But when we started out, pay and chase was a product of what we could do with our technology. We didn't have the ability to do the sophisticated things that we're able to do today. So we set up metrics that we could count, and we could count overpayments, and we could count money, and things like that. And we established a whole arrangement of focusing on fraud that was get the money out there, pay the providers, make sure the beneficiaries get the services that they need, and we'll adjust the books later. And it was appropriate for its time. And in many cases, pay and chase is still something that's appropriate today. So it's fine in certain circumstances to keep doing pay and chase. But we really want to move beyond that. And in fact, we have statutory mandates both in the Affordable Care Act as well as the Small Business Jobs Act to be able to move away from pay and chase and to get into prevention and detection. We want to get away from having just one thing that defines how our program integrity work is. It doesn't work the same in all care settings. It doesn't work the same for all providers and suppliers. It can't be the same across the board. It needs to be risk-based. We need to think about innovative approaches, some of which I'm going to talk about in a little bit. But we got requirements, statutory requirements in the Small Business Jobs Act that really spurred us on to find innovative approaches to be able to do a better job at fraud detection and prevention. We can't just talk to ourselves. We have to get away from not being public about what we're about. We need to be more transparent and accountable. Here's where I say, I want the fraudsters to see us coming, but I don't want to tell them exactly what we're doing. And I mean it. I mean, we owe the public statements about what we're doing. We need to be held accountable for what we do. We need to say what our performance metrics are and things like that. And we're committed to doing more and more of that as we go forward. We have to engage the private sector in this work. The takeaway on this is if somebody's cheating Medicare, they're likely cheating Aetna and Humana too. And the same thing with Medicaid. If they're cheating Medicaid, there's so many dual providers, they're probably doing something bad to both programs. So the last thing on here is, as I mentioned before, when the Center for Program Integrity was first created, it was Medicare, it was Medicaid. There are things we can learn from each other, from the Medicaid side and the Medicare side, and there are things that we can apply, because really what we're dealing with is providers and suppliers. And I've worked in this business long enough to know that people don't think of us as Medicare and Medicaid when some auditor shows up in the office. It's CMS. It doesn't really matter where they're coming from, whether it's the MAC or whether it's Iraq or whether it's a ZPIC or whether it's somebody else. It doesn't really matter. They're there. We need to do a better job of coordinating that set of activities, and we need to learn best practices from each program and to try and not duplicate effort in any of the work that we're doing. So this is the conceptual framework for why we do the things we do, what directs our work, how we've shaped the activities that I'm going to talk to you about a little bit in a minute. So really what all this means is we want to keep the bad guys out before they can get in and do bad stuff. As simple as that. And we do it through regs, through automated provider screening, implementation of statutory requirements such as the Small Business Jobs Act. We want to, it all starts with enrollment. We want to make sure that only legitimate providers and suppliers are enrolled in the program. And there's responsibilities for the provider community to make sure those records are up to date. We're not going to catch everybody at the front door. Some of the cleanest enrollment records are some of the biggest fraudsters. So we need to have sophisticated data analytics techniques to be able to identify aberrant behavior quickly and then to lay the foundation for doing something about it in a prompt way. And then we need to have systematic feedback from the analytics to the enrollment system so that we can improve our front-end screening. So that's the shorthand version. Keep them out before they do bad. If we can't catch them at the front door, identify their behavior quickly, and so on. So that's moved us into what we affectionately refer to as our twin pillar strategy. One part is enrollment, another part is predictive analytics in the fraud prevention system. So I'll start with a video.
For years, CMS used the traditional pay and chase model to identify and attack fraud, waste, and abuse. Here's how it worked. Step 1, pay all claims and enroll providers after passing basic processing checks. Step 2, rely on post-payment analysis and beneficiary calls to identify fraud and abuse. Step 3, suspend payments or completely revoke providers and try to collect money already paid out. Step 4, refer cases to law enforcement. Step 5, do it all over again. With millions of claims and thousands of applications, the system couldn't keep up. And because payments were automatic, we were chasing fraud rather than preventing it. Now, thanks to the Affordable Care Act and other legislation, we have a new high-tech integrated system for screening all claims before they are paid, screening all providers before they are enrolled, and preventing fraud. Every day, 4.5 million claims come into Medicare, and over 20,000 providers apply to be a part of the program each month. To process the volumes of data, new analytic tools and technology were needed to quickly approve and pay the good guys and efficiently weed out the fraudsters. CMS and its partners developed a new approach to fight fraud, creating the Fraud Prevention System and Automated Provider Screening System. These twin pillars utilized advanced predictive modeling, a technology similar to what is used in the financial sector to fight fraud. These integrated systems operate on a 4-tiered model. First, the system screens and cross-checks information against other databases such as Social Security records and complaints registered in Medicare's system. If no red flags arise, providers are enrolled and claims are paid. If an inconsistency is detected, records are evaluated against a set of rules to better understand what's causing the red flag. This data is narrowed down, sorting the simple errors from those that are potentially more dangerous. For the claims and applications that remain questionable, an alert is raised. For example, if a provider bills for time services in excess of a full day, he or she is flagged in the system. The number and type of alert associated with the provider generate a risk score. Providers who are given high-risk scores may be investigated and, if ineligible, denied, monitored, suspended, kicked out, or referred to law enforcement. This new state-of-the-art technology is now being integrated into our comprehensive fraud-fighting efforts, which have saved billions of taxpayer dollars and enhanced our ability to avoid fraudulent payments. Additionally, the recently launched CMS Command Center will drive continued innovation and improvement. It provides a dynamic environment for a multidisciplinary team to develop consistent and effective approaches for investigation and action. This is the first time federal agencies have been able to work together in such a coordinated and collaborative manner to share data and make it easier for officials to identify and prevent fraud on a system-wide basis. To learn more, visit stopmedicarefraud.gov. To report fraud, call 1-800-MEDICARE.
This is essentially a graphic depiction of our twin pillars approach. There's an application for enrollment side and a claims processing and analytics side, where we do automated screening on the enrollment side, and we do sophisticated analytics on the claims that come in, and we send information back and forth from one to the other. I'll talk more about the different kind in the green part or yellow part down here, where the different kinds of models that we use to apply to the claims, and then provide feedback and information to the enrollment system and what data systems we use. But down here at the bottom, the CPI Analytics Lab are the people that are responsible for working with our contractors to develop the analytic models that we apply to the claims payment process, because we don't go directly from data to a revocation, for example. We can't run models against claims and say, this person needs to be revoked. You have to have human intervention before we take a prompt administrative action. So the first part of our twin pillars, I said before, is the enrollment part, and there's actually two parts to the enrollment side: automated provider screening, and then there's a regulatory framework. So I think many of you know that the Affordable Care Act gave us new authorities and responsibilities to do risk-based screening. We published in February, a year and a half ago, a final rule that put in place provisions for risk-based screening that had within it provisions that dealt with payment suspensions during resolution of investigations of credible allegation of fraud. We have a provision that allows us to impose temporary enrollment moratoria if the Secretary deems it's appropriate, pretty broad and sweeping provision, which we're actually still working to implement. There are provisions in this final rule that dealt with application fees to cover the cost of some of the new screening. And then there's provisions that deal with exclusion from Medicare. I mean, if we revoke somebody's billing privileges in Medicare, Medicaid's required to do the same thing. And we can revoke people in Medicare if a state's revoked somebody. So there's a provider screening regulatory framework that deals with improvements to the enrollment process based on risk, going again back to our pastel chart that we went over at the beginning. So our office wrote this rule. We didn't do it all by ourselves, because there's a lot of things in there that came from the Office of the Inspector General and other parts of CMS and the department. But we were responsible for this. That's what our policy division does in our group. We also wrote the rule about ordering and referring services, implementing the provision of the Affordable Care Act that says in order to have claims paid for DMEPOS, home health, IDTF services, and labs, the person who ordered or certified the service has to have has to be enrolled in Medicare. And so we did, before I got back to work, an interim final rule that implemented this that we had to pend because of systems glitches and the inadequacies of the enrollment records. We finally published a rule that allows CMS to put in place automated denials of claims when there's no match between the ordering certifying providers record or name and NPI, and the enrollment record in Medicare. The claim name and NPI has to match what's in PACOS or other Medicare enrollment files. We also have automated provider screening. So we've awarded a contract that basically automatically searches existing databases, whether it's licensure information, whether it's criminal records, whatever it might be, all kinds of existing databases, public databases, things like that, making sure that the enrollment records that we have in place are as accurate as possible and that we can identify problems before folks get enrolled. The automated provider screening system is a big advancement for us, and it has great promise. It organizes data in a way that enrollment contractors have never been able to have it organized before. It does things automatically. And so in a test case, we've applied it to all physicians that are enrolled in PACOS, primarily for licensure, and we found a bunch of people who aren't licensed. So we've reached out and started to remedy that. And we found all sorts of things that we need to be working on. Again, like other output from our work, we don't go directly from what we found in the automated screening to an enrollment decision. It has to get touched by humans, and we look at it before we do anything. But this is a really powerful tool, and it'll have lots of benefit for us. We think it has great promise, and when it's implemented fully, it'll really systematize the way we can do a better and faster job on enrollment. So in our fraud prevention system, which is our other pillar, the analytics, where we catch them if they get in and escape our scrutiny on the front end, we look at 4.5 million claims a day. We apply the models from the fraud prevention system to all those claims. And the way it works is the claims get adjudicated, but before they get paid, they get screened by our models. Alerts are generated and sort of grouped around provider behavior, all based on risk and things that kicked out of the model. And then they're sent to the ZPICs to work. And right now they're working the top 100 alerts that come out of the fraud prevention system. So all these data and all the information that pop out on the models are also available. We have embedded's the wrong term, co-located staff from Justice and the OIG in our office. And ZPICs, I mentioned, I'm sure most of you have heard of zone program integrity contractors. Hopefully none of you have been in a situation where they're auditing you or doing something nasty like that. But essentially, we created them to align with the MAC jurisdictions that were created based on the provisions of the Medicare Modernization Act that replaced or started to replace FIs and carriers with MACs. We set the ZPICs up to match the jurisdictions because that's where the claims were processed, that's where the data were. That's what, if we needed to put in edits to do something, the MAC would be there, and we developed relationships. We fostered relationships between ZPICs and MACs in that regard. As opposed to program safeguard contractors that were our solution prior to ZPICs, ZPICs look at the whole range of care, not just a particular line of service. PSCs were divided up, although geographically, they didn't look at the full range of things. We've set the ZPICs up to look at everything. There are 7 zones. We've awarded contracts in 6. One of the zones is still in the procurement process. It's under protest. It's important to keep in mind that the ZPICs do their work both on an analytic basis, a proactive analytics basis, and then they have reactive work that they do as well, which I'll talk about in a second. So at the top of their list of things to do, what their priorities are the fraud prevention system and other kinds of analytics that they do, where they can identify problems and focus on them. They also respond to requests for information from law enforcement, the Inspector General's office primarily, but also the Department of Justice would say, so tell me everything you know about this guy. It's not quite a fishing expedition, but somewhere somebody has gotten some information and the ZPICs were set up to be able to respond to these kinds of requests as a partnership entity for law enforcement agencies. They also have other reactive work that they do on their own. We'll send them stuff, like some of your lawyers would come to us and say, how come you're doing this? And we'd send it out, and the ZPIC would look at it and see what they're doing or find out whether they're really doing the right thing. Or somebody would report something to us and say, I know this is fraud, you got to look into this, so we'd send them that. They really mine information that comes out of calls that come into 1-800 Medicare. We find that's a really fruitful area for us to look at. There's a nexus between a concentration of complaints and potential fraud. They look at news articles, press inquiries, things like that. And you know, their guidance in how they do all this stuff, as you all know, is in the PIM. Again, getting back to the one size does not fit all kind of theory. But since at the moment, we're dealing with a lot of things that are rule-based, or as the video mentioned, if somebody even adjusting for incident 2 is providing more services than possible in a day, things kick out. Those are things that aren't varying so much by region, but as we get into more sophisticated and other kinds of models, it may be necessary to tweak our models a little bit to reflect what the reality is in any particular geographic part of the country. So the deal for the ZPICs is whatever alerts they get out of the fraud prevention system, they need to figure out what to do about it quickly. It's like when they were first created, they were created to develop cases and make referrals to law enforcement and have somebody accept the case and take it to court and convict somebody and get jail time and get a recovery and a penalty and all that sort of stuff. And a ZPIC got a lot of satisfaction anytime a case was accepted. And so, in fairness to the ZPICs, we built them to do that. We're changing what we want them to do. We still want them to liaise with law enforcement and to develop cases and refer them to law enforcement when they see things that rise to that. But those things take a long time, and we're about identifying problems quickly and taking actions as quickly as we can. If we find people who are misbehaving and are violating our rules and continuing to do so, it may be better to revoke them first and then send all the information all the data that are available in the claims history system to the Department of Justice or to the Inspector General later. It's still all documented and available for them to take action should they want to. We just want to stop the improper activity as fast as possible. So the ZPICs are at the center of that. They collaborate with us and each other around what the proper administrative action is for each of the leads that come out of the fraud prevention system. So it's a quality improvement process. We built them to be one thing, slower acting, focusing on developing cases for law enforcement, looking at their own data and seeing if there was a there for some action, but without the premium on really trying to get the revocation for people who are really miscreant in their activities. And we're working slowly over time to make the changes in the contracts and in the relationships and to refocus some of their activities to be consistent with the long-term vision of taking prompt administrative action when we see the need to do so. And then, of course, there's the contractual framework that we need to fix to be able to accommodate it anyway. On the provider screening side, we need to make sure that people who are enrolled meet all the requirements. We're going to do criminal background checks in a more systematic way. We have a provision in our February 2nd, 2011 rule that calls for fingerprinting for high-risk providers. We're making progress on implementing that as well. We want to assign risk scores to providers based on what we learned from predictive analytics and what we learned from automated provider screening. And we want to prevent known miscreants and fraudulent providers from re-enrolling. So these things together form our overall program integrity strategy that I was talking to you about today. So that's our story. That's what we're working on. But I have time for questions, if you want.
So predictive analytics are used to identify a provider who might be committing fraud. And you mentioned there's always human intervention before removing a provider from enrollment. My question is about payment suspension. Is there ever human intervention before payment is suspended to a provider, or is that a computer model that kicks that out?
No, that's not automatic either. We don't do payment suspensions directly from data to payment suspension. There's a requirement for us to be able, well, first of all, there's different kinds of payment suspensions, and I've learned over time that although in our world there's a difference between prepay review that nets out in denials and the imposition of a payment suspension based on a credible allegation of fraud, or a payment suspension that's put in based on reliable evidence that an overpayment exists. To the provider, it doesn't matter, they're all the same thing, we're disrupting cash flow. And so I have to be mindful that, you know, perhaps you're lumping them all together. But if you're asking about payment suspensions based on credible allegation of fraud, there's a collaborative process between us and law enforcement and an analysis of certain claims and data that we have to assure ourselves that there's enough there. You know, it has to be reliable. It has to be, you know, indicia of reliability, I believe is what our reg says. So we don't do it straight from data. There are times when we think we could, but we don't.
Thank you very much. One of the things that we are hearing from our members across the country has to do with prepayment suspensions of payments. Their claims are being not only suspended, but they're asked almost 100% of the time for the medical records prior to. And these are for issues that are E&M issues, they are routine foot care issues, and there's never been evidence that there is any kind of a fraud or abuse really going on. It's just been imposed.
Okay, so just to be clear, my office doesn't run the RAC. We're dealing with ZPICs in my office, or the medic in the case of Part C and D. So, but as a general rule, we look at the appeals in our world. I'll just talk about the ZPICs. So just to level set a little bit, I know it's a problem for anybody that the ZPIC is either got on prepay review or claims, you know, either 100% or some percent of the claims are being denied. I get that it's a real problem. Nationally, in any given month, there's about 0.14% of the enrolled providers in Medicare on some form of prepay review at the ZPIC level. Not 1.4, not 14, but 0.14%. And I know that that doesn't matter to somebody whose claims are being reviewed on prepay. So when we find that, I mean, at least my goal is, when we find that we're being overturned, I think it's a waste of time for the ZPICs to continue to review things where the ALJs are finding against us.
Could you help us understand, define a little bit, the distinctive difference between the ZPICs and RACs, and how do you interact? Because with your computer modeling, are you, in a Homeland Security way, sharing information that tails off a RAC to start doing an audit?
So we do share information with the RACs in an effort to not duplicate what they do. So like if they see that we're looking at something, they don't go there. So it's unlikely, and we in general try and keep the ZPICs away from Part A institutional providers. I'm not saying that it's always the case, but the RACs are really busy there. We have enough to do otherwise. So we I meet with the people who run the RACs all the time, and we work really well together. And we're mindful of the burden associated with it, and how all of you in the real world out there can't tell the difference between a RAC and a ZPIC and a MAC, and you know, somebody else who's asking you for medical records, or somebody who's having a judgment about claims.